Welcome to Pediatric Case Review. Today we're discussing transverse myelitis in children, a rare but serious inflammatory condition affecting the spinal cord. This lecture provides an overview for general pediatricians and family physicians to recognize, diagnose, and manage this condition appropriately. Let's start with our first question. Which of the following correctly describes transverse myelitis in children? A. A demyelinating disorder affecting peripheral nerves. B. An inflammatory condition of the spinal cord causing bilateral neurological dysfunction. C. A congenital malformation of the spinal cord. D. A degenerative disorder primarily affecting elderly patients. The correct answer is B. Transverse myelitis is an inflammatory condition affecting the spinal cord, resulting in bilateral neurological dysfunction. It's relatively rare, with only 1 to 8 cases per million population annually. In pediatric populations, we see a peak incidence between ages 10 to 19 years, making it an important condition for pediatricians to recognize despite its rarity. Question 2 focuses on pathophysiology. What is the primary pathophysiological mechanism in transverse myelitis? A. Vascular ischemia of the spinal cord. B. Inflammatory demyelination and axonal damage. C. Primary spinal cord tumor growth. D. Progressive spinal muscular atrophy. The correct answer is B. Transverse myelitis involves inflammatory demyelination and axonal damage within the spinal cord. This immune-mediated process targets both the myelin sheath and sometimes the axons themselves, resulting in disruption of neural signaling across affected segments. The inflammation can be triggered by various factors including infections, autoimmune disorders, or maybe idiopathic in nature. Moving to question 3 about disease classification. Which classification system is used for transverse myelitis in clinical practice? A. Primary versus secondary. B. Idiopathic versus disease-associated. C. Acute versus chronic. D. Partial versus complete. The correct answer is B. Transverse myelitis is classified as either idiopathic or disease-associated. Idiopathic cases have no identifiable underlying cause despite thorough investigation. Disease-associated cases are connected to specific conditions such as multiple sclerosis, neuromyelitis optica, systemic autoimmune diseases, or maybe post-infectious following viral, bacterial, or other infections. This classification helps guide further workup and treatment approaches. Question 4 presents a clinical case. A 7-year-old boy presents with progressive weakness in both legs over 48 hours, difficulty urinating, and a band-like sensation around his abdomen. What is the most likely diagnosis? A. Guillain-Barré syndrome. B. Spinal cord compression. C. Transverse myelitis. D. Poliomyelitis. The correct answer is C. This case presents the classic triad of transverse myelitis, motor weakness, sensory disturbance, and autonomic dysfunction. The bilateral leg weakness, sensory level characterized by the band-like sensation around the abdomen, and urinary retention are hallmark features. The rapid progression over 48 hours is also typical, as transverse myelitis usually develops over hours to days, differentiating it from slower progressive disorders. Question 5 focuses on symptom patterns. A 10-year-old presents with back pain, lower limb weakness, and constipation. Which additional symptom most strongly suggests transverse myelitis? A. Headache. B. Sensory level with loss of sensation below a specific dermatome. C. Fever and neck stiffness. D. Progressive joint pain. The correct answer is B. A sensory level where sensation is lost below a specific dermatome is highly characteristic of transverse myelitis and represents the transverse inflammation across the spinal cord. This finding, combined with motor weakness and autonomic dysfunction like constipation, creates a classic presentation. Children with transverse myelitis typically show this triad of symptoms, though the specific pattern varies based on the spinal segments affected. Question 6 presents another case focusing on examination findings. An 8-year-old girl presents with bilateral lower extremity weakness. On examination, she has increased deep tendon reflexes, positive Babinski signs, and a sensory level at T10. What is the most likely diagnosis? A. Guillain-Barré syndrome. B. Transverse myelitis. C. Conversion disorder. D. Muscular dystrophy. The correct answer is B. The examination findings strongly support transverse myelitis. Upper motor neuron signs, including hyperreflexia and positive Babinski reflexes, are typical below the level of the lesion. The clear sensory level at T10 indicates the location of the spinal cord inflammation. These findings help distinguish transverse myelitis from conditions like Guillain-Barré syndrome, which typically presents with hyporeflexia rather than hyperreflexia, as it affects the peripheral nervous system. Question 7 addresses examination patterns. Which pattern of neurological findings is most consistent with cervical transverse myelitis? A. Hyporeflexia in all extremities with ascending weakness. B. Upper extremity weakness only with preserved reflexes. C. Quadriparesis with hyperreflexia and sensory level at the neck. D. Lower extremity weakness with normal upper extremity exam. The correct answer is C. Cervical transverse myelitis involves the upper portion of the spinal cord, resulting in quadriparesis, weakness of all four extremities, along with hyperreflexia and a sensory level corresponding to the neck. This pattern occurs because cervical lesions affect nerve tracts controlling both upper and lower extremities. In contrast, thoracic lesions typically spare upper extremities and present with paraparesis. The sensory level on examination helps localize the superior extent of the spinal cord inflammation. Question 8 focuses on the diagnostic approach. A 12-year-old presents with acute onset paraparesis and urinary retention. Which should be the first diagnostic test? A. Lumbar puncture. B. MRI of the spine with contrast. C. Nerve conduction studies. D. Autoimmune antibody panel. The correct answer is B. MRI of the spine with contrast is the first-line diagnostic test for suspected transverse myelitis. It allows visualization of spinal cord inflammation and helps rule out compressive lesions requiring surgical intervention. The characteristic finding is T2 hyperintensity within the spinal cord, often spanning multiple segments. Contrast enhancement may show the inflammatory nature of the lesion. While other tests like lumbar puncture and blood work are important, MRI should be performed first to guide further management. Question 9 explores imaging findings. Which MRI finding is most characteristic of transverse myelitis? A. Normal appearing spinal cord. B. T2 hyperintensity spanning less than one vertebral segment. C. T2 hyperintensity spanning multiple segments with cord expansion. D. Multiple scattered lesions throughout brain and spinal cord. The correct answer is C. Typical MRI findings in transverse myelitis include T2 hyperintensity spanning multiple segments with cord expansion due to inflammation and edema. Longitudinally extensive lesions extending over 3 or more vertebral segments are common, particularly in children. The affected spinal cord often shows enhancement with contrast. Brain MRI should also be performed to evaluate for additional lesions that might suggest conditions like multiple sclerosis or acute disseminated encephalomyelitis. Question 10 addresses cerebrospinal fluid findings. Which CSF finding is least likely in pediatric transverse myelitis? A. Pleocytosis, which means elevated white blood cell count. B. Elevated protein. C. Positive oligoclonal bands. D. Markedly decreased glucose. The correct answer is D. Markedly decreased glucose is not typically seen in transverse myelitis and would suggest an alternative diagnosis like bacterial meningitis. Common CSF findings in transverse myelitis include mild to moderate pleocytosis with predominantly lymphocytic cells, elevated protein levels, and normal glucose. Oligoclonal bands may be present in 15 to 30% of cases, particularly those associated with multiple sclerosis, but are not required for diagnosis. CSF analysis helps rule out infectious causes and supports an inflammatory etiology. Question 11 focuses on diagnostic criteria. According to the Transverse Myelitis Consortium Working Group, which is not a required criterion for diagnosis. A. Bilateral motor and/or sensory symptoms. B. Defined sensory level. C. Evidence of inflammation in spinal cord. D. Contrast-enhancing lesion on MRI. The correct answer is D. While contrast enhancement is common, it is not required for diagnosis according to the Transverse Myelitis Consortium Working Group criteria. The required criteria include bilateral motor or sensory dysfunction attributable to the spinal cord, a clearly defined sensory level, evidence of inflammation within the spinal cord detected by MRI, CSF analysis, or biopsy, and progression to maximum deficit between 4 hours and 21 days. Additionally, alternative etiologies must be excluded through appropriate testing. Question 12 explores differential diagnosis. A 6-year-old presents with rapidly progressive bilateral lower extremity weakness and absent deep tendon reflexes. Which diagnosis is more likely than transverse myelitis? A. Guillain-Barré syndrome. B. Multiple sclerosis. C. Spinal cord tumor. D. Neuromyelitis optica. The correct answer is A. Guillain-Barré syndrome is more likely in this case due to the absent deep tendon reflexes, which indicate lower motor neuron involvement. Transverse myelitis typically presents with hyperreflexia below the level of the lesion. The key differential diagnoses for transverse myelitis include compressive myelopathies, Guillain-Barré syndrome, multiple sclerosis, neuromyelitis optica, and acute flaccid myelitis. Each has distinguishing features that guide diagnosis, making a thorough neurological examination and targeted diagnostic testing essential. Question 13 addresses initial management. A 9-year-old is diagnosed with acute transverse myelitis. What is the first-line treatment? A. Oral prednisone. B. High-dose intravenous methylprednisolone. C. Intravenous immunoglobulin. D. Plasmapheresis. The correct answer is B. High-dose intravenous methylprednisolone is the first-line treatment for acute transverse myelitis in children. The standard regimen is 30 milligrams per kilogram per day with a maximum dose of 1 gram, administered for 3 to 5 consecutive days. This treatment aims to reduce inflammation and prevent further spinal cord damage. Early initiation is important for better outcomes, ideally started as soon as the diagnosis is established and infectious causes have been reasonably excluded. Question 14 explores treatment escalation. A 10-year-old with transverse myelitis shows minimal improvement after 5 days of intravenous steroids. What is the most appropriate next step? A. Continue steroids for 5 more days. B. Start oral steroids for 2 weeks. C. Consider IVIG or plasma exchange. D. Start immunosuppressive medications. The correct answer is C. For patients with inadequate response to high-dose corticosteroids, second-line therapies include intravenous immunoglobulin or plasma exchange. IVIG is typically administered at 2 grams per kilogram divided over 2 to 5 days. Plasma exchange involves 5 to 7 exchanges over 10 to 14 days. These therapies may also be considered as first-line treatment in cases with severe initial presentations, such as respiratory compromise or rapidly evolving weakness. The decision between IVIG and plasma exchange often depends on institutional experience and availability. Question 15 focuses on rehabilitation approaches. Which rehabilitation approach is least appropriate for a child recovering from transverse myelitis? A. Physical therapy for strength and mobility. B. Occupational therapy for activities of daily living. C. Bed rest until complete neurological recovery. D. Bladder and bowel management programs. The correct answer is C. Prolonged bed rest until complete neurological recovery is not appropriate and may actually hinder recovery. Early rehabilitation is essential for optimal outcomes. A comprehensive rehabilitation program includes physical therapy to improve strength, mobility, and gait, occupational therapy to address activities of daily living, bladder and bowel management programs for autonomic dysfunction, and psychosocial support for the child and family. Rehabilitation should begin as soon as the child is medically stable, with goals adjusted based on the severity of deficits. Question 16 addresses prognostic factors. Which factor is associated with better prognosis in pediatric transverse myelitis? A. Complete paraplegia at presentation. B. Rapid onset, less than 24 hours. C. Age less than 5 years. D. Mild initial symptoms. The correct answer is D. Mild initial symptoms are associated with a better prognosis in pediatric transverse myelitis. Several factors are associated with poorer outcomes, including severe initial deficits, particularly complete paraplegia, rapid progression of symptoms occurring in less than 24 hours, younger age, especially under 5 years, cervical spinal cord involvement, and delayed initiation of treatment. Overall, approximately 1/3 of children make a good recovery, 1/3 have moderate disability, and 1/3 experience severe disability. Early intervention is crucial for optimizing outcomes. Question 17 explores complications and associations. A 14-year-old develops transverse myelitis followed by optic neuritis 6 months later. Which diagnosis should be strongly suspected? A. Multiple sclerosis. B. Neuromyelitis optica spectrum disorder. C. Acute disseminated encephalomyelitis. D. Guillain-Barré syndrome. The correct answer is B. The development of optic neuritis following transverse myelitis strongly suggests neuromyelitis optica spectrum disorder. NMOSD is characterized by inflammation of the optic nerves and spinal cord, either simultaneously or sequentially. Testing for aquaporin-4 antibodies should be performed, as they are present in many cases. NMOSD differs from multiple sclerosis in having more severe attacks, different MRI patterns, and distinct treatment approaches. This diagnosis has important implications for long-term management and prognosis. Question 18 addresses prevention of recurrence. For a child with recurrent transverse myelitis episodes associated with NMO, which treatment is most appropriate for preventing future attacks? A. Annual influenza vaccination only. B. Rituximab or other immunosuppressive therapy. C. Daily oral prednisone. D. as needed short courses of intravenous steroids. The correct answer is B. Long-term immunosuppressive therapy, such as rituximab, is indicated for children with recurrent transverse myelitis associated with neuromyelitis optica. Rituximab, an anti-CD20 monoclonal antibody that depletes B cells, has shown effectiveness in reducing relapses. Other options include azathioprine, mycophenolate mofetil, and newer biologics for refractory cases. The goal is to prevent further attacks, as each episode risks additional neurological damage. Treatment decisions should consider the child's age, comorbidities, and specific disease characteristics. Question 19 focuses on long-term follow-up, which is not typically part of long-term follow-up for a child after transverse myelitis. A. Regular neurological examinations. B. MRI monitoring every 1 to 2 years. C. Daily serum inflammatory marker testing. D. Assessment of educational and psychosocial needs. The correct answer is C. Daily serum inflammatory marker testing is not part of long-term follow-up for transverse myelitis. Appropriate follow-up includes regular neurological examinations to monitor recovery and detect new symptoms, MRI studies performed as clinically indicated rather than on a fixed schedule, ongoing assessment of rehabilitation needs, educational and psychosocial support to address school performance and mental health, and monitoring for recurrence or development of related demyelinating conditions. The frequency of follow-up should be individualized based on recovery trajectory and specific patient needs. Thank you for watching this lecture on transverse myelitis in children. Remember that while rare, early recognition and prompt treatment of this condition are essential for optimizing outcomes. The primary care physician plays a crucial role in initial identification and appropriate referral. We invite you to follow the Pediatric Case Review channel for more educational content on pediatric conditions. If you have any questions or topics you'd like us to cover, please leave them in the comments section below. Your feedback helps us create more valuable content for your continuing education needs.